Hello, we're delighted to welcome you to this recording of an educational session exploring Parkinson's from the perspective of all healthcare professionals. This online event was streamed to an audience of occupational therapists in autumn 2020. The area that we're looking at tonight is this area around the lighthouse. And so this first sort of thing to think about when we're talking about cognition is something you're all familiar with as OTs, is the executive function. So the kind of the frontal brain type thinking processes around problem solving, decision making, abstract thinking, imagination, and lateral thinking, sort of being able to sort of imagine, well, if I keep bumping into that coffee table every time I walk to the door, what could I do, and problem solving that, and actually sort of imagining in your mind another position for the coffee table. These are all sorts of things that we do all the time, but today we're going to be thinking about the normal, or the sort of what would happen if you were well, and then understanding from that what happens in people with Parkinson's, because these things become big problems for Parkinson's. So dopamine is involved in these thinking processes, and in a moment I'll show you the 5 main routes that lead from the area deep in the brain where the dopamine is manufactured in the brain naturally, and how those routes extend out to parts of the brain and account for some of the problems we can see in this executive thinking skills. So cognitive changes associated with Parkinson's are typically reduced ability to do these executive functions, this problem-solving type thought, using that imagination and sort of thinking through scenarios and repercussions. If I do this, what will that cause to happen? All of that type of thought process requires quite a lot of dopamine. Dopamine is involved in the switching between topics, switching between themes and ideas is a dopamine-based process. So when people are, say, choosing from a menu what they want to eat for a meal, what's actually happening in the brain is we're considering each item on that menu. And so maybe there's a fish option, a vegetarian option, a meat option, whatever it is. And as we're thinking through which one do I want, what we're actually doing in our brains is we're using dopamine to switch back and forward between those choices. You imagine each sort of idea lives in its own box. And to think about it, we have to kind of open the lid of the box and think about what's inside. And then when we want to consider another choice, we shut that box using dopamine as the switch, and we open another topic box. So this process is very rapid, and we can switch back and forward, and we can make decisions based on, so say with the menu, what you had to eat earlier in the day, what you're planning to eat tomorrow. You can jump back and forward and make all those choices very easily if you've got good supplies of dopamine. But if dopamine is deficient, people find it incredibly difficult to do this switching process, this thing of changing from one topic to another and discontinuing an earlier topic in their mind to attend to the new topic. So typically in Parkinson's, what you will see is people perhaps engaging at the beginning of a conversation. They follow the flow of what's happening, but then after a few subject changes in that conversation, some of the responses you get may start to seem a bit kind of out of sync with what you're talking about. I can remember someone who was, we were having a session of OT, and I can't remember what I was trying to talk to her about, but she was very preoccupied on the transport arrangements for her following visit to the clinic, because she just had a conversation with someone else about that. And she hadn't really grasped what was going on, and it completely prevented us getting on with what we were doing until we dealt with that topic. We wrote a note, we closed that box manually, so to speak, and then that enabled her to then start to attend to what we were trying to do. So this kind of switching process in the mind, it can be quite problematic. Now I've got a picture on the screen there about IQ. I've got the picture down the bottom of the screen, and interestingly, when you assess people with Parkinson's in terms of their kind of basic IQ, having Parkinson's doesn't change their IQ. Unless you use a time constraint, ability is normal. There's a speed problem, but apart from the speed, IQ is unaffected by this type of cognitive change. So when we think about, is this mild cognitive impairment or not, when people start to have these problems with problem solving, the decision making, this kind of imaginative and creative type thought processes, sometimes it's called mild cognitive impairment, but sometimes it's even milder than that, that it's a cognitive change, but it's not actually coming onto the sort of impairment dementia type spectrum. So some people with Parkinson's simply have kind of a reduced executive function without kind of memory failure and any of those other sort of difficulties. The majority of people, things tend to progress and change into cognitive impairment, but a lot of people don't. And I've come across people with Parkinson's kind of 24 years after diagnosis, and they're still cognitively very with it, but a bit slower in conversation. So rather like when you see one of those kind of very hurried connected news broadcasts with someone like right down in the bottom of South America, and there's been a landslide or something, and they're giving a news report, and there's a time lag in the conversation between the studio in London and the person out there in Tierra del Fuego. Now, just because there's that time lag doesn't mean the person out in South America is any less intelligent. And that's what we see in people with Parkinson's when they experience these cognitive changes associated with the condition. It can just be a slowing down of mental processing and no other change. Now, people have asked me in the past about cognitive assessments, and of course we have the MOCA or the mini-mental and these different things. Some are less sensitive than others to the kind of the deficits in Parkinson's. But right in the middle of the screen there, I've got our good old friend, the clock drawing test, that you're more familiar probably with stroke patients to see that used. But actually, if you want to call it a quick and dirty assessment of cognitive function in people with Parkinson's, the clock drawing task can be quite revealing. As you can see on these examples, the majority of those are really wanting in clarity, shall we say. I wouldn't even want to begin to sort of label them further than that. But I think it's important for us to kind of understand this, because as OTs particularly, and all healthcare professionals, we need to accommodate this cognitive changes that we see, particularly in the pausing, enabling people to have time to process a question and generate a response. Just giving that extra time can be particularly useful. So if we're moving on and thinking a little bit more about this topic, let's have a look at these pathways I told you about. So in the area, I don't think you see my cursor, do you? Oh, yes, you do. So down in the brain here, where I'm moving the cursor now, this area is where dopamine is manufactured in the brain, and were this the real brain of someone who had died, by looking at this region of the brain, perhaps with the alternative section, so cutting through the brain from side to side, from ear to ear, you can actually see this region of the brain with the naked eyes as black dots. And if you've done that sort of section through the head, looking from front to back, what you'd see is a pair of like black dots, almost like horns, coming out from the central region of the brain. And that is the substantia nigra, the black stuff, where dopamine is made. And dopamine is the same as the pigment in our skin, as melanin. It's a fattier version. It's called neuromelanin. And so just like the pigment in our skin, this stuff is black in the brain. So it's manufactured just in this one region, the substantia nigra, the black stuff place. And then from there are 5 main tracts. So shown in these kind of blue arrows, going up to the basal ganglia, there's 3 arrows reaching up there. But then if you look, there's also projections going down towards the eyes and up into the frontal lobes as well. So the temporal lobes, the parietal lobes, the eyes, and the frontal lobes all receive quite strong streams of dopamine through the tracts that travel where these blue arrows are shown. So a reduction in availability of dopamine, which is the basis of Parkinson's, can be seen through looking at this diagram. It can be seen how these frontal lobe executive functions are impaired by the condition. So thinking about executive function a little more, there's a whole sort of capacity for attention that's dopamine based in several different forms, really. So attention sort of divides into kind of 2 or 3 areas, really. I've got that in the top corner there, I've got that warning sign. And that's to remind me to talk about vigilance and how we're using dopamine in our brains on a second by second basis, scanning our immediate environment for hazards. And that's the part of you that reacts if someone walks in the room suddenly behind you and something unexpected happens, or when you're driving and you just have to look at an accident. It's that part of your brain, it's the amygdala particularly, that's interested in scanning for danger. And there's dopamine involved in this process. So vigilance and maintaining safety and being aware of hazards is kind of partly dopamine driven. And then attention and concentration is also relates to dopamine. So people with Parkinson's find that their concentration is quite impaired, and they have difficulties focusing in and paying attention to what needs to be attended to in busy, noisy environments. So say in a busy clinic or a busy inpatient setting, trying to engage with a person with Parkinson's can be particularly difficult because they're very distractible. So if someone's going past with a tea trolley, or there's something happening in the next bed, all those kind of things that me and you may well be able to kind of filter out, a person with Parkinson's will find that much more difficult. So there are these deficits around attention and concentration. And then sort of recall and memory and keeping track of time. So even sort of things about managing medication regimes, people find it quite hard to attend and keep track of those things. And then in driving, again, the kind of multitasking element of driving, you know, people have to really work hard to concentrate when they're driving, and they'll find that they're much less inclined to want to listen to the radio whilst driving or have a conversation if they've got Parkinson's, because the driving will be taking all of their attentional capacity, in lieu of sort of having that more flexible process, that when driving is kind of in a non-hazardous situation, usually there's some spare attentional capacity to you know, have a conversation with someone who's sitting next to you, not on the phone, of course. So that's quite a lot of kind of, again, sort of things that it's easy to take for granted. But, you know, I've got a few hazard symbols down the bottom. So attention, you know, things like leaving the gas on, hazards in the home, safety. There can be a lot of problems around this kind of attention and failure to pay attention. And even things like attention to balance. So someone's just sprung into my mind who told me that she was very good at maintaining her balance and mobilizing outdoors, but she told me she went to a Red Arrows air display, and luckily she was standing on a sort of soft grass surface, and she realized she should have known better, but what she actually did was she watched the planes go overhead and they just fell straight over backwards. And it was about attention. She put all of her attention into watching the planes and none of her attention into maintaining her upright position. And, you know, to do that in future, we've kind of learned on this, we worked out a strategy to put one step behind it before looking up. But you've got to attend and remember to employ that technique. So, yeah, there's quite a lot of attentional issues amongst people with Parkinson's. And then that sort of feeds in really to the multitasking and the challenges around multitasking. So what we know from looking at the kind of the super able, if you look at, you know, airline pilots, some of the testing and training of pilots involves trying to overwhelm the pilot with multitasking. and there are some kind of screen-based kind of assessment tests, a bit like, driving tests, but for pilots. And they'll do things like they'll put a little red light that pops on the corner of the screen alongside a lot of other tasks. And then there's this task to cancel the red light with a particular button on their controls. And they reach the point where the pilot becomes overloaded and they're no longer able to cancel out that extra thing. So we've all got a capacity, but with people with Parkinson's, it becomes very difficult to multitask at all, because again, dopamine is involved in this being able to do several things simultaneously. So once tasks are well learned, physical actions and routines, they can almost be sort of downloaded to the autopilot system. And if dopamine is available to kind of fuel that autopilot system, you can actually run, half a dozen tasks simultaneously if they're well known to that individual. So a healthy individual probably wouldn't struggle at all to carry a couple of items in their hands, to walk up the stairs, to be maybe singing a song or thinking about something unrelated, and doing all those things simultaneously, maintaining an upright posture, controlling their saliva without any strain, but that's doing half a dozen things at the same time. But once dopamine supplies are reduced, people find it extremely difficult to do more than one thing at a time. And the capacity to actually do two things at once becomes quite challenging. So you may have noticed this thing that we encourage people with Parkinson's not to walk and talk, because when they try to do that sort of thing, then invariably there are problems with the balance. And quite opposite to people without Parkinson's, the low attention demanding tasks get abandoned when attention is put into something more complex. So if someone is trying to talk and walk and the conversation is challenging, they're likely to lose their balance or at least to stop walking. And there's even a test, isn't there, about you ask someone what they had to eat last night and you observe whether they stop walking to answer the question. And that indicates whether they're a risk for being potentially a faller, because it shows they don't have enough spare attentional capacity to run two things simultaneously. Stops walking while talking, it's called. The bizarre sort of test. But so with people with Parkinson's, it's quite a thing that, something that's more attention demanding and more complex and more unfamiliar will be performed better than something that's routine and automatic, like balance. So they're particularly vulnerable in this multitasking situation. So thinking of obviously some other elements around this executive function is learning and adopting new techniques, particularly for getting through daily life. So I'm talking here about learning new techniques for bed and chair transfers or using walking aids. And what we do know is that using a very sort of multi-sensory approach, where we maybe demonstrate the movements to the patient first, particularly with very basic movements. If people are struggling with, say, chair transfers, sit to stand, bed transfers, bed mobility maneuvers, those movements are actually learned at a time of life before people have language to describe it. So when they then want to try and do things more consciously and need to do so because of Parkinson's, getting out of a chair and off a bed and in and out of bed and turning over in bed, those can be quite problematic to do them consciously if you don't actually have a sort of verbal frame of reference of how to do the task. Whereas tasks that have been learnt after the age of about 4 or 5 tend to come together with words to describe the actions. So if you were describing to someone how you put on a jumper item of clothing, you could probably talk it through what the actions would be. But talking through exactly how you get off a chair or into bed is quite another challenge for people without any training. So when there are movement problems, actually the way that people learn once they have Parkinson's is quite specific. So we need to help people to sort of accumulate a frame of reference for something like a chair transfer. And one of the best ways that I've found over the last 24 years, to go back that, is first of all for the therapist to actually demonstrate movements to the patient, rather than spend a lot of time looking at them struggling and having problems. Through discussion, if you identify there's an issue with say sit to stand, then a good place to start is to actually demonstrate the movement sequence that would enable the person to rise more easily from the chair. The usual thing of shifting your weight to the front of the chair, just like you would with anyone struggling with that maneuver. But actually making sure you act it out very clearly and describe what you're doing as you're doing it. Just focusing in on the verbs and the nouns, the real parts of the description about, shift my bottom forward, get my feet planted, all the rest of it that you know. And actually talking through those movements and demonstrating them will enable the patient to develop a kind of like a multi-sensory frame of reference of what it is that they're going to do. And then if you swap to then starting to give them the verbal prompts to practice the movement themselves, then they know what they're aiming for because they've just seen you do it. And the same procedure with bed transfers and moving across the bed, bridging and adjusting position on the bed. It can be very useful first for the patient to observe the therapist demonstrating the movements and then do a facilitated practice. I think the other thing is this learning by doing, that's the practice side that we work alongside people. I remember we had a patient, she wanted to learn to use one of the kitchen trolleys for carrying things around that we often give to people. But she was finding the physical procedure very hazardous. When I assessed her in the clinic, she was one of these that she had the trolley right out in front of her and this big space between her and her body, and it was going to be a disaster. She lived alone. She needed to carry meals and drinks around, but we were very concerned about actually sort of adding to the risk of falls if we were to give her a trolley when we saw her working so poorly with it. So what we actually did was we had several sessions in the clinic of practice, and the OT assistant and a cue card. And we put a cue card on the trolley which said, walk tall, keep trolley close to body. So the main instructions. And then we put that on the top surface of the trolley. And then with the OT assistant, she did several sessions with this supportive practice. And this is multitasking, this is dual task training, because she was still having to walk and she was going to have to hold the trolley and push it. And it was quite a challenge, but with several sessions of supported practice, she sort of got that, and then she was safe to actually have it at home. So sometimes we're teaching people, and I've mentioned their cue cards, they need a way to remember what they've learnt with us. So again, that frame of reference, and sometimes little written reminders, little cue cards, little prompts and things like that can be very useful to help people to remember to apply what they've learnt. Another useful thing sometimes is to link new experiences that are novel to that particular person to something they have prior experience of. So down here I've got a shopping trolley and a wheeled walking aid. And so say somebody who's not encountered a wheeled walking aid before, but the physio has decided that's the best thing for them to be using now. But they're struggling to use it because it's very unfamiliar. Just the simple sort of linking in their mind through a short conversation of, well, it's not that different from a shopping trolley. Have you ever pushed a shopping trolley around, or an airport trolley? And linking this new device with something that this person has had prior experience of can be really useful. And up by the chair, I've got the light switch, because I've noticed sometimes with sometimes people find that as Parkinson's progresses, a powered armchair riser recliner can be a useful investment. But we encourage people to use their leg power when they can at good points of the day. But I've noticed often people with Parkinson's struggling with learning to use the control switch to power the chair up and down. And they've struggled quite a lot, partly because the actual handsets are poorly labelled in terms of which end is up and which end is down. And if you press the button the wrong way and it doesn't go the way you want, that really sort of knocks people's confidence. But also, again, because this is like a very novel process to most people, they've never seen a handset like that. But often if you then link it to, well, this isn't that different from a light switch. This switch is like a light switch. So I've got my picture of the light switch up in the corner. You know, linking this novel thing to some prior knowledge or skill can be a very useful technique to enable people to grasp new concepts and ideas. And then right in the center, I've got this little phrase here about the backward chaining approach. So this is something that used decades ago in learning difficulties, actually, where if an individual is struggling to learn a new movement sequence, for example, that actually enabling the person to just perform the final movement in the sequence the first time, you help with kind of like 5 steps out of 6. So say with the bed mobility and you're trying to teach someone the maneuver to get off the bed to sit up. So if you actually facilitate the movements until the very last movement in the sequence and get them to do that bit with their effort, and then you go through it again, they're motivated because they get the reward of, oh, I'm up. So that motivates them. And then the second time you go through the sequence, you get them to do the last 2 movements, and you build up in that direction so that after several repetitions, their confidence is building, and then they can complete more and more stages of the process, and always getting the ending and that reward and that motivation. So that's a backward chaining approach, and I found that quite useful on occasion to teach people when, you know, in the light of these cognitive difficulties that we're thinking about tonight. So here's a list of various different ideas, some of which I've already mentioned, but I think in terms of sort of cognitive changes, it's very useful to give a bit of background education to people about the role of dopamine in cognitive function, the sorts of, you know, simplified versions, the sorts of things I'm talking about tonight. But involving a patient and regular members of their family or caregivers is very useful, that they understand, and if a person is using new techniques to do routine domestic tasks, that other people around them understand and can reinforce those techniques. And then things like visual frames of reference. We were talking a couple of weeks ago about organisation and using calendars and planners and to-do lists and, you know, visual reminders of things. That can be very useful. Having clocks and prompts with medication charts, those sorts of things can be useful to help people to keep in control of things. Trying to get people to have routines so that they've got the right support can be very useful. Quite often people can get quite chaotic with Parkinson's in terms of their household finances, or actually their sort of actual physical environment. So it can be quite useful for people to have regular support to keep on top of those types of things. Otherwise the things can become very chaotic. We were shown a picture in an online conference that I've been at this week with the Movement Disorder Society, and they showed a picture of a patient's home, and it was just, oh, it was terrifying, the mess that this person had got into. And what they were talking about was doing these virtual meetings, and how in the clinic we don't really see the real patient. I mean, you know, therapists go into people's homes a lot more, but I think some of the doctors have had their eyes opened enormously by doing this video conferencing and actually seeing what's going on in people's homes. So quite often we need people to have some sort of support for their performance of various tasks and activities. Sometimes a cue card can be useful, just the sort of basics for preparing hot drink can be put in the kitchen to remind people of the sequence. Sometimes people need to just have a sort of give themselves some verbal prompts and talk themselves through things like the button passing techniques, where people just talk through the actions as they do them. That can help. Mental rehearsal, if people have problems getting started with a movement, that can be quite a barrier, and people can end up sort of dreading failure and not engaging in preparation for an action that's a problem. So sometimes it can be very useful to get people to get into a technique of, just before you do the movement, just imagine doing it in detail, in the right order, without problem. Imagine doing it easily. Imagine doing it So the sit to stand maneuver or something like that, or the getting out of bed. If someone feels very frozen, it can be a useful preparation to help people to do this. Run it through your mind. It's like a dress rehearsal. And what that actually does is fire up the circuits for the actual performance. This feeling or a sensation-based frame of reference is a cue. So this, I think, particularly with turning, quite a lot of people with Parkinson's get a sense of uneasiness when they're about to change direction, because they know that can be quite hazardous for their balance. And I say to people, oh, you feel that sort of sense of a bit of worry when you turn around. People have acknowledged that sometimes, you know, they get to dread things before they happen. But that can actually be the reminder, don't panic, feet first. And they can get into sort of talking themselves through a movement by using a feeling or a sensation as a cue. And then another technique to help people to sort of focus and concentrate is actually to talk through the main actions of their movements. And some people find that works best for them if they speak aloud to themselves. Other people find they can just talk through the actions that they want to do silently in their head. And this can be as simple as things like people who said things like when they grasp a cup for a drink, they place the cup back down and then their hand won't let go. And just a silent command of open hand or release cup can be sufficient sometimes to help people to cope with that sort of thing. So moving on to the next slide, I wanted to talk a little bit about Visuo-Spatial perception now, because this is another big area that it affects people on a very significant level, but is very poorly understood and sort of discussed really in the literature. So sort of looking at the bottom of the screen here, I just wanted to talk about glasses. So people with Parkinson's can either not be affected or can be very significantly affected with visuospatial disorders. And down here in Bath at Bath Spa University, someone called Alison Lee, a psychologist, did a lot of laboratory-based research with people with Parkinson's, looking at their visual perception, came up with some extraordinary findings about these kind of distortions. So we've got the picture of the lake down there on the screen, and that's to remind me about the man who told me he went fishing and the lake was sloping. So this is how it appears to people. And what is actually happening is in the optic nerves, there's dopamine involved in the transmission of the visual images into the back of the brain, where vision is processed all over the lots of regions of the brain. But dopamine is involved in that pathway. So you can get this asymmetrical slowing of the visual images. And what do they call an increased latency of a 200th of a millisecond. So basically the signals from each eye, from the half of the visual fields of each eye, don't arrive in the brain at the same time. And this can account for these distortions of space where people see horizontal surfaces like a lake as sloping. They can perceive a staircase as very frightening. They often struggle even with just a simple curb edge to judge the depth and the distance. And escalators, moving stairs, are incredibly hazardous for people who've got this kind of visual distortion. In a line bisection task, this is demonstrated by people, you know, really struggling to find the center of the line. In a virtual reality test, people were shown like stripy lines, like down the middle of the road, you know, broken lines, and those were shown sort of rushing past each side in the peripheral vision. And then the task was point in the direction you feel you're traveling. So when they sent these stripy lines past the peripheral vision in the test subjects with Parkinson's, they were getting these very odd sort of pointing out to the side when these lines were passing at the same speed. So in these virtual reality headsets, they were able to speed up one side sufficiently that the person would eventually point to the center, while the other side was still going quite slow. So really bizarre distortion. So obviously these things can lead to trips and falls, These people often have foreshortening of their depth of field, so that objects are often placed onto a surface and miss the surface and break. So they smash a lot of stuff in the kitchen. They misplace objects onto tables that aren't quite there. And glasses don't help. So a lot of people spend maybe months or years struggling with these pretty well invisible problems, traipsing back and forward to the opticians, complaining about their glasses, getting different prescriptions. It still doesn't work, because unfortunately lenses can't change any of this, because, as I've said, it happens in the optic nerve and behind. And what the lenses do is change vision between the front and the back of the eye. So quite often people get quite frustrated, and there's this double vision thing as well I haven't mentioned so far, where people get bizarre sort of double vision. They get double vision of only certain elements of what they're looking at. So things like all diagonal lines are doubled up but nothing else is, or everything through the window is doubled but everything in the foreground isn't, or you know, very peculiar things that people get. I've had someone talking about trying to pick up tablets from the table and having double vision then, and it being very difficult to coordinate the pinch grip. But double vision normally is everything, is all or nothing. So this sort of double vision is Parkinson's double vision, and it's very bizarre. And I'm always asking opticians about it when I go for my own glasses, and they don't come across it and they don't get trained much on it. So it's a dopamine responsive symptom though, so it fluctuates. And if it does come to your attention, one of the things to discuss with the consultant prescribing the medication, because smoothing out the dopamine regime can have good benefits on this, so that when the dopamine levels are high enough, then the double vision issues or these other visual distortions tend to reduce. And then as the next dose of medication is due and the dopamine levels are falling, then these visual distortions creep in again. So getting a more steady cover through the day with long acting and those sorts of medication preparations can be quite helpful in this situation. And unfortunately, the opticians are yet to be able to offer anything that can have much impact on this. But particularly be aware of advising people, if they have got these problems, about a variety of ways that they can cope, and using proprioception more, checking a surface is within reach before placing an object, using banister rails, maybe using a walking pole or something when out walking to check the depth when you're stepping off the curb, and avoiding escalators if at all possible in the underground and public places. Take the lift, use the stairs if you can. So then moving on to the final part of today's talk is looking at motivation and apathy. So again, dopamine, favourite chemical of the brain in many ways. So dopamine is a kind of oomph factor, it's a motivator, it's a get up and go chemical, it's a start, get going, take action chemical. So when levels of dopamine are depleted in the brains of people with Parkinson's disease, what this is often represented as apathy. So is apathy a problem or not? Well, there's a couple of things to discuss there, because quite often members of the family and friends of an individual with Parkinson's do find apathy a problem. They find that the individual is not as sociable. I mean, you know, so lockdown restrictions notwithstanding here, you know, but, you know, a person with Parkinson's who develops apathy, which can happen very early in the condition and before even motor symptoms develop, and apathy can be an issue. People just become less motivated to do things they used to enjoy. And it can be a problem to those around them, more than to them themselves, so that the individual who maybe is more apathetic, not particularly bothered, quite happy to sit around, sit in the chair, be with their memories, be very passive. But others can find that kind of behaviour change can be quite disturbing, because, you know, it may limit their own social activities and engagement with other people. So sometimes apathy is not a problem for the patient. is a problem for others. And sometimes it's a matter of just people needing a little bit of education around this. But other times it can be more of a sign of depression and mistaken for depression. And what is apathy, and is it depression? Are they the same? Are they different? And does it matter? Well, it does matter, because it's about whether people are suffering or not. So with apathy, generally, if they do engage in things they used to enjoy, they will feel a sense of pleasure and they will enjoy that activity. So with a bit of encouragement and, a bit of chivying along, a person may be, encouraged to, enjoy an activity with other people. And once they're doing that activity, they will feel pleasure from it. Whereas if a person is actually experiencing depression and they engage in something, they don't get that sense of pleasure, and they perceive unhappiness and sadness. So depression is different from apathy, and it can be quite difficult to tease those two things out. But if people are experiencing actual depression, so they're low mood, they're feeling sad all the time, the things they used to enjoy just don't give pleasure anymore, that's the time when perhaps treatment could be useful. Again, sometimes it's just simply changes in the dopamine regime that the consultant can organise that can lift mood. And that will feed in then to people being more outgoing, perhaps slightly more motivated again. But other people, the apathy, it's not much of a problem, doesn't need treatment. But perhaps others around that person need a little bit of explanation of what's going on. But there are some approaches, and I just attended a Movement Disorders Society conference on apathy. I did a whole session on apathy, and they came to the same conclusions as one of my master's students about 8 years ago, which was that to lift apathy, music is one of the most efficacious things, and live music apparently was particularly efficacious. But music, singing, walking, these are all things that are actually quite good for re-engaging people's kind of energy and interest in things. So those are some of the things that might be useful to consider if people are looking for ways to sort of move themselves back into living life a bit more fully. Thank you for your attention. We trust you have found this session interesting and that you'll make time to view other recordings in this 6-part series.
To find out more about a Map of Parkinson's app and a Map of Parkinson's course for healthcare professionals, please visit phoenix-aragon education.uk.